It's nice to see all of you here. Beautiful day. Aren't we so glad the rains are over and the weather forecast for the whole week is supposed to be sunny and warm, and these are the reasons why we live in the Northwest. Well, today we're honored to have Russ Reinhardt, CEO for Providence, Willamette Falls, be our guest speaker. He's going to share with us the vision that they have in their expansion plans. And if you've driven by the hospital recently, you'll see that there is a lot of construction taking place across the street right now. It's all will be medical office space. My wife recently had surgery at Willamette, Providence, and had an excellent process. The help was amazing, so I can't recommend it any better than that. So we're pleased to have Russ go ahead and share with us a PowerPoint. Before we get started, though, I'd like to introduce Police Chief Jim Band, if I can find him here in the room. There he is. He's going to say a few words about the recently approved bond measure.
Thank you. Hello, how are you? How's your lunch? So I just wanted to take a minute to quickly thank the Oregon City Business Alliance. Our building project, if you haven't heard, was approved by, it was just under 81% in favor, so we got the thumbs up from the community to go ahead and start building our building. The whole process started at, I guess the bulk of this has been about 4 years, from kind of the idea about whether or not a fee would work, to the first time that we went to the voters, to the much clearer message that we recently went. And the Oregon City Business Alliance has been in support with letters to the commission, letters to the community in the paper, arguments in favor both times, and just super supportive of us. And I just have to thank you publicly for taking such a strong position in favor of our project. Kind of the next steps that you'll see in the community is we're doing an RFP right now for the first of 2 different architects that we'll have in our design process. And the beginning of next year, you're going to see community outreach, some open houses, and looking for some different ways that we can get community input into what the community wants to see at that site and in our building. And it's going to be some work, and we're hoping to break ground around July of 2019. That's the best intention right now, so we'll see. So thank you very much, OCBA.
Thank you. You bet. Thank you. So I'd also like to recognize 2 of our city commissioners that are here today. Nancy Hyde, thank you for coming, and Brian Shaw, appreciate your presence. So if I understand correctly, the hospital employs about 750 people, and I would imagine with this new expansion, that number is going to be going up. So, all right, well, with no further ado, I'd like to turn it over to Russ, and we'll have time for question and answers afterwards. So I'll let you go ahead and put that in
there. All right. Well, thank you for having me here. Again, I'm Russ Reinhardt. I'm the Chief Exec at Providence, Willamette Falls. Been there a long time. We're going to show you some pictures here of the campus and so forth as we expanded. When I first got there, we didn't have either medical office building. We didn't have the new emergency department, imaging department, or ORs. We've remodeled all of them. So there's been a lot of growth in the last 15, 20 years at Willamette Falls, and it's going to continue. Obviously, we're in a community, as you all know, with the Cove and so forth, that's growing. A lot of housing development, Happy Valley, Canby, and so forth. We serve all those areas. So we're very fortunate as a hospital to be in a growth area versus an area that's restricting. So we're trying to keep up with that growth, and honestly, that's our biggest problem right now at the hospital, is the growth. Where numerous times we're at capacity on our inpatient side. If anybody's been there, Kent, you've been there, you know parking is an issue on certain days, especially on Tuesdays, Wednesdays, and Thursdays when we do a lot of our ortho cases and so forth. But it's a good problem to have, and we're trying to address it. So I'll talk a little bit about that as we go forward. So I'm going to go a little back before I go forward. How many people know this building or where it is? A few. This building is on J.Q. Adams and 6th Street, and that was the original hospital. So Willamette Falls, some of you may know this story, Willamette Falls was founded by 8 physicians. So 8 docs came together. This was a for-profit birthing center, and they came together and decided they wanted to compete with the Oregon City Hospital. They actually went out and got loan guarantees. They got Hill-Burton funds, and they bought this building. And they started a hospital. They opened a full-service hospital, and they quickly realized, you know, this just isn't going to be adequate for our growth and as we move forward. They literally did surgeries. If you talk to Dr. Perch when he was live, they did surgeries in the basement, and they had to go up a flight of steps, do a 180, and go up another flight of steps to get to the surgical beds. So not an ideal situation. They changed the name from Doctors Hospital from Hutchison to Doctors Hospital, and turned it into a nonprofit hospital, nonprofit. Then they started looking for land. 2 sites that they looked, when I talked to some of the founding members, one is where we currently are. I guess that was a farm, cross division. The other site they looked at was where the college is. And of course, I'm very envious of the college and the area they have. Would have loved it if they'd bought that, but you know why they didn't buy it? They said it was too far out. People wouldn't go that far to go to the hospital. So that's why they started. And now look at their growth, 60 years later. So in about 1961, this building opened. They broke ground in 59, and in 61, this was the original. And actually, part of our problem is if you look at the wing coming out to the left and even the wing in the back, that's still there. That still exists today. So, 50, 60 years later, when we go in to remodel those buildings, you can imagine what we find in the plumbing and asbestos and the HVAC systems. So every time a project you think is going to take 6 months, it usually takes a year because you're finding a lot of these old buildings. But we've grown a lot since that time. So that was the first building. And then we started growing, and this happened in my lifetime. As you can see, Birthplace opened in January 1991. Actually, it was 90, I believe, because my daughter was born in 90, and she was born there 4 months after it opened. So fairly new addition. If you've been there, it's a beautiful 14-bed unit. LDRPs, we call them, where you deliver in the beds and in the rooms. You don't have to leave the room. You can see Medical Plaza 1 opened in 1995. That was our first medical office building on the campus. That building now is 100% occupied. I have zero space, literally zero space left in that building. So as that building filled up, we realized we needed another medical office building. And if you've been up to the campus, there's Plaza 2 is immediately to the east of that building, and we put in a parking structure. Plaza 2 is now 100% occupied. We have zero space in either office building. So a good problem to have, but it's a problem nonetheless when your community's growing. You want to grow with the community as we move forward. Our main entrance, if you've been up there, you can see our current main entrance. You're going to see in the master plan, when I show you the picture of the master plan, our front entryway is pretty inadequate. And if you come into the hospital, it's a very, very small lobby built years ago. We want to redo that. It's just finding the funds to do that. It's the problem right now. But eventually that is in the master plan, and we'd like to redo the entryway, enlarge the admitting area, the lobby, the chapel, et cetera. And I'll show you that. This was our last major project was this one. And we literally had a little 8-bed emergency room. They were curtained rooms. We had 2 little trauma rooms. Now we have a 20-bed emergency room. That was what we put in here. At the time, if you recall, we shelled it out on the top floor. So as you look at the rotunda now, that is a child and adolescent psych unit, 22-bed, one of the only ones in the state of Oregon. So people come from all over Oregon to Oregon City to access these services. We're the only unit, child and adolescent psych unit, that sees kids under 13 years of age. So we have a 6-bed child side that's perennially almost full all the time. Surprisingly, those young kids cause more problems than the adolescents do. We have what we call code gray, where they have to respond to a kid that's angry or hurting somebody or trying to, and the child side is much more aggressive than the adolescent side, interesting enough. So at the same time we did this project, though, we enlarged our diagnostic imaging area, because at the time, again, we had a very, very small, antiquated, old equipment and so forth. So now we have a beautiful new diagnostic imaging area. All our equipment is digital, so you don't have to use film anymore. State-of-the-art type of stuff as we move forward. So that was a great addition. But again, that was if you can imagine the dollars as you go forward, we did a complete OR remodel before this. It was $10 million. This project was $20 million. So it's like every 5 years, it seems like the costs double. and any contractors can tell you that, or any developers and so forth. So let's talk about the master plan. So this is the campus. This is the vision out here. The back of the campus back here, Trillium, is in the back there. So as you look at this, this is our approved master plan that we went through the city. So it's a 20-year plan. We are right now, so as you look at this, 16th Street's down here, 15th Street comes into here. This is the front of the hospital, in the middle of the hospital. The big pieces of the master plan, obviously this medical office building that you're seeing built right now, and unfortunately we couldn't get a schematic. We had an artist renditioning, so you'll just have to come up and look at it when it's done. So, but that's happening right now. It also calls for an addition to birthplace right here. The new front entry right there is in the master plan. And then this project, two of them back here, is a sensory utility plant, and then a remodel, actually tearing down our old day surgery wing, adding a couple ORs and a whole new day surgery wing, okay? So we've been approved, so we have to go through system finance, right? And that's up in Renton, Washington. So obviously the MOB's approved. Moving forward, we hope to open the second quarter of 2018. I've already got it almost full, believe it or not. So I should have put another floor on it, but I know the neighborhood would have gone crazy if I'd done that, and I appreciate that. So we didn't want to go another floor, but it is almost full already because of the demand, okay? Northwest Primary Care is going to move into there and enlarge. I think they have 2.5 docks in Plaza 2. They're going to move in there and move up to 7 docks. So they want to bring more primary care into our region, which is a good thing, right? I mean, there is a primary care shortage. And by the way, please ask questions as I go through this, or just raise your hand. Yes, William?
Why is it called day operating?
Day surgery?
Day surgery, yeah.
Because people come in, have their surgery, recover, and then they go home. So you have inpatient. If you're an inpatient, you have to go upstairs and go to an inpatient bed. But day surgery is literally, you come in that day, have your knee surgery, recover in the bed in the day surgery wing, and then you're gone. So that's why we call it day surgery. So again, Q2 2018, Northwest Primary Care. The child and adolescent psych, we have a clinic, an outpatient clinic that's in the hospital. It's not ideal to see kids, obviously on an outpatient basis, in the hospital. That's going to move next door. And then anybody been to our rehab unit? Okay, the few of you that have been there, you realize that half of your rehab is getting to the unit, right? Because it's in the basement, you have to go downstairs, you have to cross the street. It really is not ideal, and it's very busy, actually. Within that space now, we also have cardiac rehab, okay? So cardiac rehab was a new service. We put it in the back of rehab. It's at capacity now. It's a wonderful service where if you've had a heart issue, heart attack, MI, whatever, you come there, they recover you, they rehab you, so you can go about life, and the risk of a second heart attack goes down significantly, and the quality of life goes up. So that program needs to grow. So what we're going to do is we're going to move the outpatient rehab into the new medical office building. So it'll be much more accessible, easier for patients to get in and out, and then we're going to enlarge the cardiac rehab, take the rest of that area for cardiac rehab as we move forward. So that's the plan, and that's all part of that medical office building budget and part of the plan as we move forward. Oh, we did get an artist renditioning, didn't you? So let me talk a little bit right now before I go forward. I'll show you a picture of the building. We do have a project into the system right now, and it's part of that master plan. It's that whole day surgery wing, tearing that out, putting in a sensory utility plant to support it, and then we'll build out a new wing with a shelved space on the top of it for future growth. $48 million package that's with the system office right now. We were supposed to hear in August. Here we are in October. We still haven't heard, so we just don't know. Honestly, Providence has been very tight on capital. They've had some tough financial years, so they've cut way back on the capital allocations to all the regions. So it's a little bit frustrating because it's in our master plan, but we'll see if we get approved. We're hoping for 2018 to start it, but we're not sure.
So, Russ, I don't see any increase in the envelope of your property there, which, you know, I can see the new structures, but I don't see where the new parking is going to be. Are you able to add on to that parking structure you have, another couple of stories onto that structure you already have, or what are you thinking for parking?
So he's asking about future parking, so forth. Okay, so what we'll probably do is the plan is to add another layer in the back there. We can't go on top of the parking structure. It wasn't stressed for that. But we can go another level up, similar to the parking structure in the back when needed at this point. We do have a parking lot with a MOB. If you noticed across 15th, we're going to add about 45 spaces there. So, okay. Any other questions? Let's look at the building then. So this is what the new medical office building is going to look like. That would be the corner of 15th and Division. You know, looking at the building, the entryway will be around the back side of that. Be a good looking addition. We're going to redo the streets. We have to do Division, half a Division, all of 16th and all of 15th because of the building there. Actually, we've done 15th and 16th already. A little bit of wood look, kind of similar to our emergency department, et cetera. So. And then the next slide, that's really hard to see. I apologize for that one. But that's our cardiac rehab as it's a plan. As we move forward, I mentioned that we're going to enlarge the cardiac rehab program and take the rest of that rehab building. We're actually moving the inpatient therapists upstairs so that they're closer to the patients and they're out of that space too. But that's that lower level. It's actually, just to give you a perspective, I showed you birthplace, and most of you know where birthplace is. It's in the lower level of birthplace. That's where our rehab services is today. So again, it's people have to go downstairs, cross the street. It's very inadequate for our patient population. So. Yes?
Question for you. When I went on a tour of another hospital 2 years back, I was fascinated by the cost to outfit one room with technology. What is one room cardiac rehab area cost?
So cardiac rehab is more like a gym, if you think of it. So it's a larger area. But if you think about an OR, so we're going to add 2 ORs in that project in the back. They're about $1 million for each room. For an OR. For a med surg room, I hear it's like $40,000 now. We haven't done that in a while. So anytime you say medical in the construction world, it's going to cost you. Okay, it's just more expensive because of all the rules and regulations, and they have to do this and that. So.
What about technology?
Technology is a huge problem right now. Our cost, I should say, when you look at an MRI, $2 million. But everybody wants to keep up with everything. You want the new mammography units, $375,000. So technology is incredibly expensive. And it's tough in the healthcare industry as you try to keep up with the Joneses and so forth. Even, like I said, Providence, you think of Providence. Providence has fallen a little behind because we have had some tight capital. But you can't let that happen. So how do you keep up with that? And then, of course, Medicaid, Medicare is cutting. So your reimbursement's going down. So it's kind of a wicked cycle as we're moving through. It's a tough industry right now, to be honest. But good question. I did just want to touch on our total joints. I don't know anybody in here has had a total joint at Willamette Falls, but we do a lot of total joints. We become basically a center of excellence. We have 4 surgeons that are doing total hips, total knees, and total shoulders, okay? We have 1 doc. This is incredible when you think about it. Now, I would not want to be the last patient for this doc in the day. But on Tuesdays, he comes in, and we do what's called a fast track. So he will go to one room and do a total knee, and he'll go right next door, and the anesthesia is already there. They're all set up. He'll do a total hip. Come back over here, do a total knee. He does 9 surgeries in a day, if you can imagine. I don't know how he does it physically, because there's a lot of hammering, and you can imagine. Again, I would not want to be that 9th patient, to be honest. So I'll just warn you, make sure you get early on the list if you do it. So, but he really is. He's an excellent surgeon, outstanding revisionist and so forth. And he's got a partner now that joined him. We've got another guy coming over from Meridian Park. So we're doing a lot of total joints. That, just so you're aware, creates a lot of issues. Because if you know orthopods, they don't like to take call. Taking call means answering the ED. When somebody shows up to ED with an ortho problem, you call that doc who's on call. Well, they also don't like rounding on their patients in the weekends. So what they do is they do all of their surgeries Tuesdays, Wednesdays, and some on Thursdays so they can get them out by Friday so they don't have to round on their patients on the weekends. So you can imagine when I'm doing that many surgeries on a Tuesday, Wednesday, Thursday, it takes a lot of beds. So my inpatient, I get really tight in the inpatient, and then the parking is horrible. Because these guys are coming in and out and so forth. But that's kind of what happens with the total joints. Great program, though. that he's put together. We have a pre-meeting. People meet pre-surgery as a group, and they talk about what to expect, what's happening, and so forth. And then they have a post afterwards, meetings with the patient. So it's really about recovery, what to expect, pain control, and so forth. Okay. So growth. Let's talk again. I've talked a little bit about growth, but this is where we're headed, and this is part of that master plan. That outpatient surgery expansion, the central utility plant, that's the project we have right now up at the system office, okay? To keep up with our surgical growth, basically, is why we need that, and to keep up the central utility plant. We have an HVAC unit in the basement of our hospital that services a large portion of the hospital. It's kind of our workhorse. You know what year the manufacturer stamp is on it? 1954. I think it served us well, and these guys, but we don't have enough duct tape to keep it together, so that's why we need a central utility plant. Longer range is the main entry expansion of birthplace, and actually remodel of our med-surg rooms. As we move forward, our med-surg rooms were remodeled about 20 years ago. They're a little outdated. They're small, so we might actually put some new ones in the shelved space. But that's where we're headed for the growth as we move forward. Okay. I think I talked about the outpatient thing, but that's what the surgery, the current surgery waiting, that would all be part of this remodel as we move forward. Okay. I did want to just touch, let's go to the next. I did want to touch on this. This is mentioned this is a really unique service. It was actually moved from Portland to Willamette Falls, but like I said, it's one of two in the state of Oregon that serves adolescents and the only one that serves children. It's almost full 100% of the time, 22 beds. So again, we get kids from California, Northern California, Southern Washington, Idaho. But it's hard to imagine here we are, and people don't think of Oregon City and think of a unit like this that serves such a population. Very vulnerable population, by the way. It's a beautiful unit. It's actually, when I was at Portland, they did not have an outdoor. We put an outdoor play area for the kids on top of the roof. We're able to accommodate that, so it's been a wonderful addition to our services. And I don't know if you realize, Providence serves more behavioral health patients than anybody in Oregon. And they also serve more children than any other system. You don't realize it, but they're being served in Portland, they're being served at St. Vincent's, so we're kind of spread out, but we're trying to coordinate that better. If I was to give you one, I'll come right to you, one of the biggest Achilles heel, I guess I would call it, or problems in healthcare, in my opinion, is behavioral health. Behavioral health is in absolute chaos. Children's behavioral health services, the state continues to drop funding. They continue to close beds. They close foster home, et cetera. You guys know the story. So we get these kids in here. We get them stabilized. That's what we try to do. It's an acute care unit. So get them in 6 to 10 days, get them acute, get them back on their meds, get them stabilized, and then get them to a residential facility or wherever. And a lot of times we're holding these kids 60, 90 days, 120 days because there's nothing available out in the community. So it is a big issue. So
on that, kind of a two-part question. What is the future of, I think it's a great resource probably that a lot of places in Portland go that you do children. What is the future of adult care with Providence and with the backdrop? I know there's several hospitals in Portland, in the Portland area, just went in on this Unity Center project, right, that I'm sure and I don't know if Providence is one of them.
We are.
And why? And so can you talk about the future, and then why not being a part of the Unity Center?
So we talked a lot about Unity, but we provide, again, more service than Unity does. Unity was actually going to, if we joined them, we'd be cutting adult beds, and we would have cut children's beds. So instead of doing that, we're trying to get our services more in line. We've hired a new executive of the behavioral health units to really work better together. So we do partner with Unity, like especially the Children's Center. If we have a kiddo in our ED and we're full, we try to talk to Unity. But it was a conscious decision not to join it because we provide more services than they do now. We think we do it well. We have an adult unit at both Prov Portland and Prov St. Vincent's. We have an outpatient ED, behavioral health, in St. Vincent's. We just opened, I don't know if you heard, at Prov Milwaukee, they opened a 19-bed geri psych unit for geriatrics. It's full. I mean, it was full the day they opened it. So we do a lot of behavioral health services. But again, I still think it's in crisis, honestly. So.
Can you talk about the emergency department expansion serving children?
Yeah, so what we're looking at is when you get those kids and you can't place them, you know, the worst place for those kids is in the ED, right? Sitting in an ED bed. Again, we had a kid in there for 9 days. He was sitting, a 13-year-old kid, sitting in an ER room because we couldn't find a space for him and we didn't have space upstairs. We did get him placed eventually. So what we're going to do is open our foundation, raise money. We're going to open in a vacant area a 3 to 4 bed, what they call pediatric emergency services. So it's not an ED, but it would serve kids that when they're in the ED and we can't find those placements, they could move in there and it's much more therapeutic, much more friendly, softer, et cetera. So that unit is coming underway, so thanks for reminding me of that. And anything else I forget, Renee, just let me know as we move forward. Okay, so last thing I'm just gonna touch on is Providence as a system. You know, you talk about, we're broken into regions, so we're part of the Oregon region, 8 hospitals, multiple clinics, about 17,000 employees in Oregon. But we're obviously a big system, and we just joined. You can see all the different things. I won't go into a lot of this, but Swedish joined us, Cadillac in Richland. We had PacMed, which is a large physician group, so we've grown tremendously. Well, we just did another huge merger about a year ago, and that was with the Sisters of St. Joseph of Orange. So Providence was in Alaska, Washington, Oregon, Montana, and California. Touching Southern California, basically. St. Joseph has 16 hospitals, so we were 36. They have 16 in Northern California, Southern California, 1 in Texas, and 2 in New Mexico. So we joined and came together. So now we're a huge, large system for all the right reasons, I think, to leverage our size, our technology, trying to get that technology, our payers, et cetera, as we move forward. We are very fortunate in the Oregon. When we continue to grow, Oregon region is always exceeds all the other regions. We also have a health plan. Providence Health Plan now is one of the largest. When I first joined Providence, remember Willamette Falls was independent. I didn't mention that until 9 years ago. 9 years ago, actually, this month, we joined Providence. And at that time, Providence Health Plan, I think, had like 250,000 members. It's over 600,000 members now, so it's grown. So that's the Oregon region. But the system, like I said, now is 7 states. It's huge, multi-billion-dollar corporation. Sometimes it's very frustrating for us little guys when you're trying to get things done, but it takes a while. It's not very limber, or nimble, I should say. So with that, I'll just open up to questions on any of that or Providence in general.
The question was, how profitable are you to the other, I'm sorry?
Providence Medical Centers.
So how profitable we are you talking Willamette Falls?
Yes.
I knew Craig would ask that, by the way. Craig used to be on our board. And so we are one of the most profitable hospitals in the Oregon region now. We did turn that corner when we first joined them. I was on the watch list for the system office for probably 3 years, but obviously as we consolidated, brought together the efficiencies, the economies of scale, we do very well now. We're one of the few hospitals, honestly, the last couple of years that hit budget and actually exceeded budget in the Oregon region. But like I said, the Oregon region overall does very well. The other thing I'm very proud of, honestly, is we look at a lot of quality metrics. As a matter of fact, I just got my quality metrics for last month, and it looks at a variety of things like C. diff and CAUTI, which is infections, central lines, et cetera, those type of things. And Willamette Falls and Milwaukee were the only 2 that were green all the way across in all our quality metrics. So I'm very proud of that. Our infection rates are incredibly low. We had the lowest readmission rate, which is something everybody looks at, the payers, Medicare, Medicaid. We had the lowest readmission rate probably the last 3 years at Willamette Falls, which means we're taking care of patients, getting them well, and then get them into the community. And if they come back in 30 days, that's a readmission, and it counts against you, and you get actually penalized for that. But again, we had the lowest, so we're pretty proud of Willamette Falls.
Thanks for coming today. I'm on the OCBA board. I live in the Bethany area, so St. Vincent is my area. So I have two easy questions. One, what goes on across the street here, and how does that relate to the hospital? And the other is, what do you see as the components that are driving the cost of health insurance and medical care? Is there a legal component, regulatory, capital investment requirements, et cetera? So, thank you.
Geez, you gave me a softball on the first one and then tears me up on the second one. Okay, I'll answer the easy one first. So that's our community education center, we used to call it. I think it's Willamette Falls Community Center now. That was, money was raised for the community. This was my predecessor. It was his dream to have an education center. And so as we move forward, we raise the funds, we built the center, and we give it free to community members if it's health related or behavioral health related. They can use the things. Unfortunately, once we join Providence, there's limited meeting space around Providence, particularly now because Portland's having parking issues, and so everybody's like saying, no, you can't use our conference rooms in the hospital. So Providence is actually using the building an incredible amount. Renee was just telling me it's tough to get in there now because it's the Providence meeting facility, and people have discovered it. You know, the people of Providence, easy parking, easy access versus going to St. Vincent's, trying to park, and it's a beautiful building, you know, and right off of 205, so people have discovered that's what happens there. So the cost of healthcare, boy, there's a lot of factors that go in there. There's no magic bullet in my mind. I think it's a variety of things. It's us. We as Americans, we want it now. We want the best. We want the outcomes, right? So that's a part of it, is the demand, yet we don't take care of ourselves. There's a lot of obesity, et cetera. And you look at other nations, their obesity levels are way below ours, and their diabetes and so forth. So part of it is the population. A lot of it is the payer system. Medicaid, we lose money on every Medicaid patient in general on average by a lot. So, but we see Medicaid, right? And they come through our EDs. So that's a portion. So then the commercial payers, we leverage them to cost shift to the other payers. So it's a payer model. Part of it is technology, which you mentioned. Everybody wants the latest, greatest. Being Americans, I don't want a 10-year-old MRI. I want that 1.5 Tesla, you know, whatever. And so it's demand. So it's just a lot of combinations of technology, demands, et cetera. I think a big portion of it, I listened to a guy, he really talked about, if you don't know this, in all the developing countries or the developed countries, that we have the most expensive health care in the United States and the worst health outcomes. I mean, I shouldn't say outcomes, but the worst health in general. When you look at France and so forth, they all have a single payer system. So they're doing something right with that single payer, where ours is, we got Medicare, Medicaid, commercial, et cetera, and self-pay still. So it's all the above. So again, not an easy answer. So good question though. William.
Russ, unlike other facilities that provide services to our community, such as our library, our college, police station, public works, and so on, the hospital does not take any tax money directly from the citizens. So the question is sometimes asked, do the fees of the patients pay for your facility? And I suspect not all of it. Can you expound on that?
Sure. So he's talking about that we don't get tax revenue from the citizens, but we do pay a hospital tax to the state, by the way. That's fairly new. That was just approved that we're going to actually pay taxes. We're a nonprofit. So to answer you, yes, our money comes in the form of either our foundations, so philanthropy, or it's from insurance companies and individuals like yourself. We charge, obviously, give you a bill at the end of the day, and hopefully you have insurance, or we all have insurance, and that's how they pay us. So we have to balance that to make that work, those levers. Obviously, we don't want to charge too much, and the insurance companies don't want to pay too much, so it's this battle, constant battle that goes back and forth. So that's, I don't want to go into too much depth on this one, but back to your thing on cost. People have told us we're too expensive. We know we're too expensive, and we've gotten too expensive. Medicare has told us. So what's happening, particularly in the Oregon region, is there's a shift. In the past, I got paid for volume, right? Come in to have a knee surgery, I bill you, I get paid. Now payers are saying, and employers are saying, enough. What we're gonna do is we'll give you a set amount of money for the people in this room, and you're at risk, Russ. So you keep them healthy, here's your budget, you keep them healthy, keep them out. So now they wanna keep them out of the hospitals and the EDs. Get them to their primary care, get them healthy, you'll make money. If you don't, you're gonna lose. 50% of our revenue stream in Oregon comes in that form right now, what we call at-risk agreements. And if you've heard the buzzword now, it's population health now. Instead of health care, it's about trying to keep the population healthy. So Providence is now looking at, and you look at the factors that affect your health, I might impact maybe 10% of the physicians of the healthcare system. It's housing, food security, education. That accounts for like 80% of your health. And yet we have people living in poverty and so forth. So Providence is starting to look at that because we realize if we're going to take risks, we've got to keep people healthy. So it's a real fundamental shift in healthcare. That's pretty interesting. A bit scary, yeah.
Russ, my little company actually works with Providence for the healthcare side, and I have to congratulate you on the amount of support and effort you put into the wellness programs that are attached to your insurance coverage. Our experience numbers are driving renewal rates that are under 10% growth in cost of insurance. And that's not what you hear right in the marketplace. That's not what you're hearing on the news. And a big part of it, I really do think, is that ongoing support of those wellness programs. So thank you for doing that. That being said, of every dollar you bill out, how much of it is charity care or uncompensated?
So charity care has gone down, but it's about 5%, 6% of that. On average, for every dollar we bill, even with the insurers, because insurers don't pay what we charge. So when you see your bill, you know that. Insurers have gotten discounts and so forth. We get about 70% on the dollar right now on that. With Medicare, with Medicaid, that's an overall average, right? Medicaid, we get 30% of the dollar. So Medicaid reimburses about 27 to 30% of those dollars. So it's tough. In the back there, he's had his hand up a couple times.
Can I have Russ expand on that for a second about why charity care has gone down with the Affordable Care Act and how we're getting more people insured, which is why, can you talk about that a little bit?
You're not supposed to ask me tough questions, Renee. Come on. So that's a good point. Y'all have heard the Affordable Care Act. We don't know. Sounds like we have it around for a little while. A lot more people covered under the insurance, so Medicaid. What happened though is we went and see a lot more Medicaid now. So our charity care went down significantly, but our Medicaid went up. That's where most of that Affordable Care Act impacted. Again, we lose money on those dollars, and our bad debt went down for a while, but then it started rising again. And we were like, why is that when we're covered and we have these Medicaid patients covered? Well, it's because a lot of individuals in Medicaid in the programs in the exchange, they chose very high deductibles, right? And then all of a sudden they can't pay them, and then we write it off. So now we're kind of getting a double whammy where our bad debt's rising, but our Medicaid population has risen too. So it's good that they're covered. We support that, but what we want to do is get them to their primary care doc and get them healthy. And we haven't done a good job with it, frankly. In the back.
Dr. Joel Robertson, just retiring from Oregon Health Science University, had a dream of going throughout the rural parts of Oregon to establish a linkage to OHSU. He was my eye surgeon, by the way. He helped me a lot. But the issue is, you guys are central to Clackamas County, Molalla, Colton, Estacada.
Right.
Have you thought about any ways to maybe outreach in any way? Your model that I come back to is your education center, which is so good.
Right. So he was asking about outreach, if we're doing outreach in Willamette Falls, and we have. We do have an outpatient center, I don't know if you're aware, in Canby that we built. That's got an immediate care center, primary care docs, rehab services, and a full diagnostic imaging suite. That was a real conscious reach out. We have centers in Happy Valley now, Providence does, and we have primary care docs all over the place, and that's one way you outreach and so forth. So yes, we have thought about it. And honestly, OHSU on the rural side has done a fantastic job. They've really done a good job with outreach. So Providence is kind of running behind the ball trying to get in that game too, but OHSU kind of takes the rural health. So, well, he's asking about our birthing center and how much it costs and how many kids we have born through there. We have about 1,100 births a year through that place. We could take more. Our OB group is trying to grow as we speak. We do have times where we're full, basically. And as far as cost, my youngest is 22, so I don't know how much it costs. I'm getting a little facetious. I know it costs a lot, but I don't know the answer to that, to be honest. So it's a great unit. I mean, we call it the happy unit. You know, a lot of people, when the other units, they're sick or they're ill or they're getting a total hip, there you're having a baby. So it's a happy unit.
Two simple questions, I think. From your chart there, the 14 supportive housing programs, can you tell us a little bit more about what that is? And then what is your experience as far as opioid-related emergencies?
Opioid?
Numbers. Are you seeing the same kind of huge increases that seem to be nationwide?
Great questions. Affordable housing, most of those, I believe, and help me out, Renee, I think are in California, and they're just what they're saying. They're low-income housing that Providence owns and has built for neighborhoods as they see. We just did you talk about collaborations, and we weren't in the Unity collaboration, but the systems came together, Legacy, Providence, so forth, and put in $120 million, something like that, for Central City Concern in Portland to build more affordable housing. But that's kind of that population health that they're talking about. So, and your last question, opioid. We're seeing two. I mean, the big one, honestly, is the IV drugs, is IV heroin that we're seeing. And on any given day, we'll have a couple patients in there. I can tell you a story. One was so dramatic. The guy was trying so hard that he would put the codeine, grind it up and put it in applesauce so he could get the high that way, and then try to shoot it through his IV. I mean, it's incredible epidemic right now. It really is. I agree with you. But yeah, we're seeing it big time, in all our facilities, not just Clackamas County. Kind of like the meth use appears to have gone down. The sheriff would know. He's raising his head no. But this IV drug use has gone way up as far as the ones we see, but you probably see. He's saying it's still there, so it hadn't gone away.
So what's your background and how do you blend business, not-for-profit, medical technology?
What's my background? Good question. So I was a CPA by training. I spent 6 years in one of the big 6 firms. They ended up selling their office in Portland. So I got the luxury, literally, of seeing the door close. And all that time, for 6 months, I was able to look for work and so forth. Honestly, this is how I got into healthcare. I interviewed at Willamette Falls just as practice in October, okay? Then we closed the office in March, and right before it closed, I didn't have a job, kid on the way. I was really trying to get to Bend, to be honest with you. Didn't want to go to healthcare. The gal, the CFO at the time, called me, said, I'd like you to come up and interview. Again, we still have the position open. Okay. She offered me the job on that day and wanted the answer the next day, and I said, can you at least give me the weekend, because I wasn't sure about healthcare. Got into healthcare. Eventually, a year later, my predecessor moved me to CFO, so it was a great career move. That's how I learned the business, basically, as controller, CFO, learned the finance side of it, the insurance side of it, supply chain, and then he started mentoring me. Getting big piece of healthcare is working with your docs, getting with the physicians and making alliances and so forth. And so that was part of my growth as I went there. So I've been CEO now about 15 years. So thanks for the question. That was an easy question.
How is the homeless population impacting the emergency department? And does Providence have any specific plans or hopes or dreams to address those issues in an alternative way? So
the homeless population, that's a very good question. It has impacted our ED. When they moved my father's heart up here, we saw a dramatic increase of indigent people coming in, and when they come in, there's clothes issues, some of them don't have feet, there's behavioral issues. So it has impacted our ED, and they deal with it. I know it's a tough population, and try to get the right agencies involved and so forth. We haven't talked specifically about the homeless population, but we are part of the Homeless Coalition. We have a couple people that are actually working with that group, trying to facilitate them and so forth, and then I try to go and so forth to see how can we help that population out. But it's affordable housing. So they did it in Portland. I hope sometime they'll come out in this Clackamas County area. So, good question, though.
If we were to look at this chart 5 years from now, and Providence were, you guys were just keeping your current market share, so we're looking at the baby boomers growing and
right,
not the baby boomers, the millennials, and starting to have babies. So you're just keeping your market share. The demands of the medical industry to keep up with what I think is going to be population growth. How would you guess some of these numbers might change 5 years from now?
That's a good question. I don't know whether we have the clinics, 829 clinics, if you see up there. I think you're going to see more investment, number one, in technology, and Providence is really investing heavily in not the technology we're talking about, like in my facility, but in smartphones and video healthcare, et cetera. We have kiosks now where you can go see a nurse practitioner in Walgreens, for instance. So I think you're going to see more of that. I don't think you're going to see many more hospitals, even though I think the demand there, because we're trying to keep people out of the hospital, but we know the baby boomers are coming. So that's going to backfill the people that we're trying to keep healthy out of the hospital. So I would anticipate that you're going to see a lot of clinic growth, a lot of digital growth, digital healthcare basically, which you don't really see out there, but not much in the way of beds, like at Willamette Falls and so forth. Maybe a little bit of growth, but Renee, anything you?
I think that Russ, do you think there'll be a shift from the current baby boomers to the millennials as far as the type of healthcare?
I think there already is happening. They don't understand how they can take their phone and book a flight, go out to the airport, and just, don't even have to print a ticket off. They just show you your thing, all on your phone, and you can't make a primary care visit. Or my primary care visit, they want it now, just like we do, but my primary care is a week out, and I don't feel good now. Why can't I look at a nurse practitioner on an iPod and get a diagnosis and a prescription? That's the change that's happening with the millennials, and they're driving that change.
And we can do that.
We can. Yeah. We've invested in that technology. It's fairly new to us, and we're working out the kinks, but you're going to see a lot more of it. And we as baby boomers, because I was 1 year away, doggone it, but I'm a baby boomer. So as we age out, I think we're going to have more demands on the healthcare system to be more responsive, quicker. What's going on? Why can't I get to see my doc? So, okay. With that, thank you very much. You guys asked a lot of great questions.
Thanks. Appreciate it. Well, a lot of great questions. Healthcare is a big subject, as we all know. If you turn on the news every day, a lot of discussion about how do we try to build on the programs that we have in existence today to not only continue to increase the coverage, but also to make it affordable to everyone so that no one is left out. And that is the big challenge. How do you afford that? I know Oregon expanded Medicaid tremendously, and obviously you're saying you lose money on every one of your Medicaid patients. So how do you make all that add up in the end? So I wish you the best. The other thing I'm really excited about is here in Oregon and the Northwest, we are so blessed to have such easy access to delicious fruits and vegetables that are so fresh. But one of the obstacles that we face is people just don't have the time to prepare the meals or don't have the desire to even use their kitchens very much. And so I encourage the hospitals or any medical facility, when they're seeing their patients, prepare just a one-page handout of a list of different food items that are very affordable. actually less expensive than most other items that you buy in the store, but have so much fresh nutritional value for them. And just suggest, why don't you try a few of these? And here are a couple ways to prepare it that's simple, but tasty and flavorful and has great color. And if we can just get people to kind of start thinking about that a little more. I look at our tables today, and every single plate looks to be completely clean. Now, that's a good thing. That's a great thing, because the food was delicious. And I ate a lot of cauliflower, but I also ate a lot of other things that I probably had more of on my plate than I should have. But, that's just something we can build on.
I agree. So a little in response, I just want to give you guys a head. That's a great point. We do have nutritional counselors in the hospital. We have diabetic educators that go up to the floors to talk to diabetes patients and try to coach them into better meals. Milwaukee Hospital has done something that's pretty incredible and unique to that I'm aware of. They've opened up what they call a teaching kitchen through their foundation. So they have chefs that come in. Primary care docs can actually prescribe to go to the teaching kitchen. The patient comes in, they teach them right in front of them and have them prepare healthy meals, show them how to do it. They have food there, healthy food, that they give these indigent patients and so forth, that needy patients, and it's a wonderful program. It's grown like crazy, and now we want to replicate it here and other places, because it is teaching particular low-income patients how to eat better. So.
Yeah, and as you're saying, the direction of healthcare is kind of going, we're going to give you a certain amount of money to keep your population healthy. And we've all known the saying, an ounce of prevention is worth a pound of cure. So if we can keep them out of the hospital by taking better care of themselves, everybody benefits. So anyway, let's hope we can just continue to build on that. Again, thank you very much, Russ and Renee, for helping to put together. I'm looking forward to seeing your building get closer to completion, getting a chance to meet a lot of the new doctors that you'll be having on staff. And we're just so fortunate that we have you available for our community. Not every city has that, to be able to say we've got a major hospital right in our backyard. So we'll see you next month. Thank you.